All right, thanks for having me, Chris. Nice to meet you all. Who here is a first-year student? Okay, a few people. And who are second-year students? I feel like I know most of the second years because I TA'd some of your small groups. Okay, I'm going to talk for probably about 30 minutes and then do questions because we ended right at 1, right? Or a little bit before 1? Right. Okay. So I was going to tell you a little bit about cancer medicine and challenges with drug approval, maybe how I kind of keep up with the literature in cancer medicine, maybe one specific drug. Then we can talk about anything you want. But in terms of background, I did my medical school at University of Chicago. I started medical school 20 years ago. I finished 2009. I was a resident at Northwestern in general medicine. And then I did my Hem/Onc fellowship at the National Cancer Institute in DC. And then I was on the faculty in Oregon Health and Science for 5 years, and I've been on your faculty for 5 years. And I'm professor in the Department of Epi. All right, so I always wanted to start with, this is like a true story of something that happened to me in clinic, and I thought it's a nice way to frame this talk. So one day I was in clinic at San Francisco General Hospital. And actually shown here is a charcoal sketch of me in clinic. I had a pre-med student, she was from Texas. She came up for a month and she was shadowing. And when she finished her rotation, she mailed me this big, and it's like on an easel, a big charcoal sketch. And it was like a super nice gift. She's an artist. So she drew this by hand. And I really appreciate it. It's like a super sweet thing to do. There are a couple things about the drawing, however, that were like artistic liberties. That's not really the way I am in clinic. Number one, I'm wearing a white coat in the picture. And when I joined UCSF, for budgetary reasons, they didn't give me a white coat. So I actually don't have a white coat anymore. And the other thing is I'm wearing a stethoscope. And I actually never carry a stethoscope in clinic because my only physical exam is a PET CT. And so that's the world of oncology. We don't listen to hearts and lungs. We just image the body if we're curious. So one day I was in clinic, and my patient is a 65-year-old woman with multiple myeloma. That's a blood-based cancer. That's a cancer of the plasma cell, which is a terminally differentiated lymphocyte. And my patient is 65, and she's been getting treatment for many years, but her sister comes in with her to the visit. So this is really common. You get a family member, a loved one in the visit, and it's the loved one's question that's often the hardest question to deal with. So the 60-year-old sister, younger sister, she doesn't have cancer. She's just a healthy woman. And she asked me this question. She said, "Hey, doctor, do you think I should increase the amount of exercise I do to protect myself against getting multiple myeloma?" So she doesn't have cancer. She's a healthy person, but she has a first-degree relative with multiple myeloma. And she wants to know if by doing more exercise, she's going to be less likely to get multiple myeloma. I thought to myself, this is a really interesting question. I mean, one is, if you have a first-degree relative with myeloma, are you at that much higher risk of getting myeloma than the average person? That's the first question. And second, is exercise protective against myeloma? And then the third is, how much should she do? It's a question of amount. So I was trying to think about how to answer this question. And I gave her the answer that I think most doctors give. You know, the answer when you're not exactly sure what to answer, but you want to give them the most honest thing you're thinking. I said, I always think exercise is beneficial. I myself like to do a lot of exercise. And I would do it for general and cardiovascular health. General health and well-being, and particularly cardiovascular health. I think that's the biggest benefit. I'm not sure if I would necessarily do it to protect myself against multiple myeloma, but I think you should do it for cardiovascular benefits. And then she fired back with a doozy. "But didn't you read the new study, doctor? The new study." And I'm supposed to be the kind of doctor that reads these studies. And I said, come on, didn't I read the new study? I mean, come on, did I read that new? And of course, this was the study. This was the study. Getting enough exercise lowers the risk of 7 cancers. It was out by the American Cancer Society. They put out this press release. Look at these people fighting off cancer as we speak by running. And they say getting recommended amounts of physical activity is linked to a lower risk for 7 cancer types, according to a new study. I said, okay, let's get to the bottom of this. I pulled up the study. It was amount and intensity of leisure time physical activity and lower cancer risk. It's actually exactly the correct study for this patient sister's question. They took data from 9 prospective cohorts where they made people fill out these questionnaires for years, and we know at the end of the time if they get cancer. They've got 755,000 people. And they're looking at what happens to almost 800,000 people over decades of follow-up. We know how much they exercised, and we know if they got cancer, we know what kind of cancer. And they say that for 7 out of 15 cancer types, there's a statistically significant lower risk of cancer. So my first thought was, how many cancers are there actually? I was like, what? Why 15? You know, I know about like breast cancer, lung cancer, colon cancer, lymphoma. I started to rattle off cancers, and it turns out that even in lymphoma, we got 200 different lymphomas. Then we got hundreds of other cancers. We got all these rare cancers. Actually, as a cancer doctor, it pains me to admit that I do not know how many cancers there are. There are probably thousands of cancers. But they chose to look at 15 cancers. I don't know why these 15, but they picked 15. For 7 of the 15, about half of them, they found a link. But the other 8, they didn't find a link. Okay, that's what caught my eye. I looked in the paper, and would you believe it? The exact answer is in the paper. There is one of the 15 happened to be multiple myeloma. And this is the relationship. Okay, this is the hazard ratio. 1 means you're roughly at the risk of somebody who didn't do any exercise. Of course, it's baselined at 1 for someone who doesn't do any exercise a week. And then it shows you, as you increase your metabolic equivalence a week, what's the relationship between more exercise and the risk of getting multiple myeloma. And apparently there's 1,300 people got multiple myeloma. And here's what they find. Oh, and the p-value is 0.05, which I heard that's a good number. And as you see, if you exercise 7.5, 15.5, 22, it's protective, isn't it? You're less likely to get multiple myeloma. Over 1 is harmful, below 1 is protective. But then something happens. You know, it's like too much of a good thing is bad. It starts to, wear off. You do too much exercise. You know, it's a really like J-shaped curve. We see this sometimes like BMI. It's what caught my eye. Well, the first thing I had to admit was that even though I went to medical school 20 years ago, and even though people talk about exercise, I did not even know what this MET is. You guys, do you talk what an MET is? MET? I didn't know. And so I was looking at the paper. I got the family in the room, and I want to know what a MET is. I did the only honorable thing a doctor can do, which is I tilted my monitor away from the patient. I looked it up on Wikipedia. And on Wikipedia, would you believe, here's what you find. You find that METs are grouped based on light intensity, moderate intensity, and vigorous intensity activities. They're different types of METs. And different activities, like if you did a yoga for an hour, it's 3.3 METs. I was doing a lot of biking on flat surfaces. I was going a little bit faster. That's 6 METs an hour. So everything's got their own METs. One of the things jumped out at me on this list. I noticed sexual activity was scored in METs, but it was benchmarked to a 22-year-old. And as an older person, I found that deeply offensive. Deeply offended by this. I was hurt. Okay, so then I look in the supplement, and the story's even more complicated. The relationship between myeloma and METs, we can stratify by moderate and vigorous intensity. For moderate intensity, look, it's protective. That's these below 1. But for vigorous intensity, it doesn't do anything. There is no link between vigorous intensity and myeloma. It's only protective if you take it easy. What the heck is this? You know, this is really baffling. So how did I feel? You're telling me you got this big data set. You could have looked at any cancer, and they're probably from thousands of cancers. You picked 15. And you're telling me that for 7 of the 15, there's a link, but not the other 8. You're telling me that for multiple myeloma, exercise is good for you, but only if you do 15 hours, not if you do 30, and only if you take it medium, not if you take it really hard. So how did I feel after thinking about this? I felt like this. I felt confused. I felt baffled. And I have pictures of myself in all emotional states. Now, why was I confused? I was confused because, to me, it's implausible. I'll be the first to admit to you, I do believe exercise is good for your health. But why should a little bit be good? Why should medium intensity be good and not hot, vigorous intensity? This creates an implausible pathophysiology in my mind, right? What's the biology behind this? Next, the potential for multiple hypothesis testing. There are thousands of cancers they could have looked at. In fact, they might have looked at other ones. They're only presenting 15 in the paper. And the relationships there only for 7. And what are they adjusting for? Are they adjusting for age and sex and race and socioeconomic status? Are they adjusting for prior history of heart disease? What are they adjusting for? You could pick and choose what to adjust for. You have probably, in this data set, the potential, they're showing you 15 analytic plans, but you might have been able to generate 100,000 or 1 million or 10 million analytic plans. Why these 15 out of all the hypotheses we could be testing? The next thing I was thinking, what about confounding? What if you were sick and that made you both less likely to exercise and more likely to have cancer? So like, what if I had lupus, and lupus is making me less likely to go out there and run, and people with lupus at a slightly higher risk of cancer? What if that's the confounding variable? It's not the exercise per se, it's that people with diseases don't exercise as much. What if that's the reason? And then finally, measurement error. This is all predicated on the fact that everything in this study, in this data set, is based on self-reported exercise. And that's not really that reliable. People don't tell the truth. So what did I say to the patient? I said, do I believe staying active is part of living a healthy life? Yes. Would I specifically do it to avoid myeloma? I would do it as part of general cardiovascular health. And when she asked me if I read the paper, what did I tell her? I said, no, I didn't read that paper. I'm sorry about that. I didn't read that paper. Okay. So my point here is that it's kind of just a story to loosen you up. It's not really had any point. But the point is, you know, when you look at observational studies of claims of things that cause or protect against cancer, they're all extremely volatile estimates. They're all extremely uncertain. You could take a cookbook and open it up, and you could take a dart and you could throw it at a random ingredient in that cookbook, and there's an 80% chance that someone studied whether or not that ingredient is linked to cancer. When you have so many people running so many analyses, you will get any conclusion you want. Among that 80%, most of the time, you'll find studies that say it protects against cancer, causes cancer. Same with exercise. So do I believe exercise is good? Yeah. Might exercise lower the risk of cancer? Probably a little bit, insofar as it lowers weight, would be my speculation. But do I think it has any magic to do with myeloma? No. And her risk for myeloma is actually probably not much more than the general population. So I told her, really, you should exercise, but myeloma should be the last thing in your head, in your mind. All right. I'll tell you one more story and then we'll pause. This is a true story. This is like literally just true. The first thing was true too. That actually happened to me. And I actually did look at the Wikipedia, which, you know, if a patient catches you looking at Wikipedia, you got no credibility left. You got to, at least let's get to up to date. You know, Wikipedia's, they're going to wonder where I went to med school. Okay, so one day I opened the New England Journal of Medicine, July 25th, 2009. And this is the actual article I see. This is what we oncologists do for fun. We like to read these things. And it says, maintenance olaparib for germline BRCA mutated metastatic pancreas cancer. I said, oh my God, that's like a buzzword city. So let's take it one at a time. Maintenance. Maintenance means in cancer, you got a patient who you normally wouldn't give a treatment. You just watch them, observe them, and now instead of that, you're going to maintain them with the treatment. That's maintenance. Olaparib, that's a drug made by AstraZeneca that costs $14,000 a month. It works through double-stranded DNA repair. Did you guys learn about homologous recombination deficiency and homologous repair? Yeah, well, I don't know anything about it, but that's apparently how it works. It works through that mechanism. It's a PARP inhibitor. Germline BRCA, the BRCA gene is a gene that some people are born with, and it's passed along in families, particularly Ashkenazi Jewish families. And if you have BRCA1, you get breast and ovarian. BRCA2, you get bowel, and you get bladder, and you get some pancreas cancer too. Germline means it's being passed in families. They're born with it. So they're saying, we're going to test this new pill in people who have germline BRCA mutations, like Angelina Jolie did, who develop metastatic, means it spread to other parts, pancreas cancer, adenocarcinoma of the pancreas, which kills 40,000 Americans a year and is what Patrick Swayze died of. Steve Jobs had pancreatic neuroendocrine tumor, different cancer. Okay, so we're going to take a drug that's 14 grand a month, maintain it for people with this germline BRCA mutation. Why are they doing it in these germline BRCA mutation people and not everybody with pancreas cancer? It's because this works through double-strand DNA repair. This has something to do with double-strand DNA repair. They think there's a synergistic effect if you happen to have this mutation as well. So there's some biology reason. All right. Well, I knew all that a little vaguely at the time. But then I opened my email. And in my email, I'm a Stat News subscriber, or at least I was. And I get this article. It's called Forget Controversy. AstraZeneca's dynamic duo wants to dominate the market for cancer drugs. And it's got a whole little coverage of this paper that just came out in the news, that came out in the New England Journal. And this is the quote about that paper. It's unbelievable. This is a true quote from the newspaper. It's unbelievable, said Baselga. It validates the principle we've been fighting for all these years, that even the most difficult disease, even the disease where you think you're not going to win, if you find the genetic vulnerability, if you find that, then those giants, they crumble. I said, oh my God, that sounds good. I mean, giants are crumbling. This is a difficult, this is going to crumble the giant of pancreas cancer. I was like, this has got to be a good study. Now, there's a photo of me and Baselga from many years ago, but you don't know Baselga, so he was a character. He was a guy from Barcelona. He is a hot-tempered guy, but he was a lot of fun and a pretty smart guy, but he passed away, sadly, a few years ago. I also noticed this. This is University of Chicago Medical School, where I went to medical school, my alma mater, and they had a press release on this POLO study, and it says this: when we saw the progression-free survival data My first reaction was a little scream of joy. We finally made real progress in the treatment of a subset of patients with advanced pancreas cancer. She's screaming for joy when she sees these results. So this is good. It's as good as it gets. So I always tell people whenever I read an article, oh, you're all hungry, there's no food. That's what, okay. That's what's missing here. That's what's missing, okay. Whenever I read an article, I'm sorry about that, I didn't control it. Whenever I read an article, I always say, if you want to go to sleep, read it cover to cover. But if you want to understand what they did, have questions in your mind and find the answer. So what did they do? Is the control arm what you would do in your practice? A clinical trial can only change your practice if the control arm gets what you do in your practice. What's the primary endpoint? Is it a clinical or surrogate endpoint? What about other measures of activity and efficacy? This is what I ask. So here's a study, POLO. They take those people with germline BRCA mutation pancreas cancer, and then they give them the standard of care, which is platinum-based chemotherapy. It's called FOLFOX. And they give it to them for 16 weeks, 4 months, and then they say if your tumor does not have evidence of progression, meaning it ain't 20% bigger, you're allowed to enroll and be randomized 3-2, skewed randomization, olaparib, $14,000 a month, or sugar pill. Sugar pill. Okay, olaparib or sugar pill, and then they're going to measure outcomes. So my first question was, is the control arm what you would do in your practice? Well, I'm not usually in the business of giving someone 4 months of a very effective treatment, and if it's working or shrinking their cancer, stopping it altogether and then putting the patient on sugar pill. I'm not in that business. In fact, none of the people who ran this study were doing that at the time of the study. So to me, my first problem with this study is this control arm. I think these people shouldn't have been olaparib or placebo. It should be olaparib versus continuing the platinum therapy that's still working. That's what I think it should be. And over the years, I've been presenting this at different conferences and like globally, I've been talking about this study. And I kept saying that, it's really kind of delinquent of these investigators. I even said it's unethical of these investigators to stop treatment. It's really bad. And then finally they responded. They said, look, Prasad is wrong. Here's why. Prasad is saying that we are at fault for only giving 4 months of treatment. But if you pull the original study from the French group Prodige that justified that platinum-based therapy, FOLFIRINOX, you pull that original study and you read it closely. It says the median number of treatment cycles administered in the platinum group, this is the platinum group, is 10 cycles. And each cycle is every 2 weeks. So 10 2-week cycles is 5 months. And Prasad's not happy we give him 4 months. I mean, we're practically giving the same amount of treatment. They're saying he's nitpicking. We gave 4 months, in the trial they get 5 months. That's what they said. And so then I said, wait a second. It's not exactly an apples and apples comparison. Here's why. The POLO trial, you're not allowed to get in the study if your tumor gets worse in the first 4 months. But this study enrolls everyone from baseline. So how many of these people's tumor gets worse in the first 4 months? And the answer is it's about 1/3 of people. They get worse in the first 4 months. Those are people not in the POLO study. And the 5-month average is all of these people are average for 5 months duration of treatment. But imagine if your tumor gets worse in 2 months, you're not going to get 5 months. You're going to get like 2 months. If you remove the worst third of people from the study, the average goes to 7 months. So they're supposed to get 7 months of treatment. Now they're only giving them 4 in this study. So they're getting shortchanged by half. Okay, we'll pause here. Why don't we take like a 5-minute break so you guys can grab some pizza? Should I resume? Okay, we left off this riveting saga, I'm sure, for everybody. We left off. They're running this study where they take these patients with germline BRCA mutation, they randomize them to the new drug or placebo, sugar pill, and I think that that's bad. They shouldn't have given sugar pill. Reason is that this trial they give it indefinitely. Then they fire back and they say, well, in the trial they only gave 5 months, we give them 4 months, close enough. And I say, well, then you're including all these people who could never have gotten more than 4 months because they progressed before that. If you average the people who are enrolled in your trial, it would be 7 months, so you're giving about half. But then I realized it's even worse than that because this trial enrolls everybody with metastatic pancreas cancer, but germline BRCA mutation patients tend to be younger than the average age, and for a number of reasons, they do better with platinum therapy. It also causes DNA adducts and homologous recombination pathway, and so they actually do better, have even more treatment, and I won't bore you with how I estimated it, but they should be getting about 12 months or more of platinum-based therapy, but the trial only allows 4. So it's an extremely negligent and unethical study to halt this treatment, in my opinion. Okay, so like I say, whenever I read an article, what did they do? And they randomized people 3-2 to olaparib or sugar pill in germline BRCA mutation pancreas cancer who didn't progress in the first 4 months. Is a control arm. Were you doing your practice? No, because I'm not a bad doctor. I'm a good doctor, at least try to be. What was the primary endpoint of the study? Next question. The primary endpoint was this: progression-free survival. This is a time to event endpoint Kaplan-Meier curve. By definition, at the beginning, nobody could have experienced the event of interest, and it happens over time. And olaparib does better than placebo. The events happen more in the placebo arm, and this is the difference between the two. Hazard ratio is 0.53. It's significant. This is the figure that when she saw, she screamed in joy. She screamed out in joy. See, I don't scream out in joy for a few reasons. One, unfortunately, 100% of people have the tumor get worse. There's no cures in this. That makes me sad. Two, even though there's an improvement, I think it's modest. Their cancers are getting worse between 4 and 7 months. It's like a 3-month improvement. So I think it's still maybe at most a baby step. Is it a clinical or surrogate endpoint? We don't talk enough about it in medicine, but there are 2 categories of endpoints. Clinical endpoints are endpoints that are inherently meaningful to people, how long you live and how well you feel. And surrogate endpoints are stand-in endpoints that are usually measurable, but are not, strictly speaking, those 2 things. So if I told you your LDL is 185, it's a surrogate. It's a surrogate for cardiovascular disease, but you don't feel it. You can't tell. You don't know. You can't feel the difference between a 75 LDL and a 180 LDL. So that's a surrogate endpoint. Your hemoglobin A1C, surrogate. Your blood pressure, a surrogate. But living longer, living better, having heart attacks, strokes, those are clinical endpoints. But what is PFS? I said it's a time to event endpoint, but what exactly is it? Well, we scan someone at baseline. We measure their tumor. It's got a diameter, cross-sectional area, volume, and progression-free survival is the time until one of 4 things happen, whichever comes first. 1, the patient dies. That's the survival part of it. So if the patient goes along after treatment, 2 weeks later they die, that's scored as an event, a survival event, a PFS event. The next thing that could happen is there are new lesions on the scan. The thing you measured is unchanged, but the lungs had nothing in it. Now the lungs have new nodules. That's a progression event. The next thing that could happen is the tumor gets bigger. If it gets more than 120% bigger, it's called progression. 119% is called stable disease. So it's an arbitrary radiographic cutoff. Nobody's walking around at 118% saying, I feel fine, 119%, I feel good, 122%, oh, I feel terrible. It doesn't happen that way, The symptoms and the cutoff are separate from each other. You guys probably hear about PFS all the time in this class. PFS, PFS, PFS. Well, this is what PFS, right? Because people talk about PFS so far. Oncologists love PFS. The 4th thing that could happen is the tumor shrinks. If it shrinks more than 30%, it's called a response. And here we measure progression from the smallest it ever gets, from the nadir value. So 20% growth from 70% is 84%. That's progression. So progression is the time until one of these 4 things happen, whichever comes first. But they're not equal things. This is arguably not as bad as this, right? And they're lumping it all together in this composite time to event endpoint. All fields of medicine have composite time to event endpoints. Cardiology has like major adverse cardiovascular events. We have PFS. That's our favorite. What about other measures? What about activity and efficacy? What about survival? And what about that? I showed you what a response is, 30% shrinkage. What about activity? So I always look at this. So in the paper I looked at, and I saw something super interesting. In the olaparib arm, the group getting that $14,000 a month cancer medicine, the response rate, which means of 100 people who get it, what percent have that response, 30% shrinkage? It's 20%, 1 in 5. 1 in 5 people have the tumor shrink from the cancer drug. And I completely believe it. It's a cancer drug with real side effects and it fights cancer. 1 in 5, it shrinks. Okay. Placebo is a sugar pill made of sugar. I'm no expert on sugar. Patients always ask me about sugar, but one thing I know is sugar doesn't shrink cancer. But yet I noticed the response rate is 10%. 1 in 10 people with the giant, the bad pancreas cancer, has tumor shrinking 30% on sugar pill. What the heck? That's a lot. I jumped back when I saw that. I said, that's a hell of a sugar pill. That's the most potent sugar pill I've ever seen in my life. I'm also an old-fashioned doctor. I look at overall survival. These are the overall survival curves that were present in the original paper. I noticed one thing. They're pretty close together. The p-value 0.68. There's no significance here. The old saying in oncology is if you can fit the laser pointer between the curves, you can give the plenary session. But I can't even fit the laser pointer in between the curves here. There's no benefit. So how do we put these all together? Not all of you get that I'm joking. Okay, now how do we put all these together? There's a progression-free survival benefit, but no overall survival benefit. And sugar pill is shrinking the tumor in record rates. Why? Someone tell me, why do you think in this trial, sugar pill was the most effective sugar pill anyone has ever seen? Why is it shrinking tumor way more than it should? Yes? Good answer. So, if you look at every single study ever conducted, there can be measurement error. He's absolutely right. There's measurement error. You could take the same person, scan him twice, or you could put people on sugar pills, scan them again, and sometimes through measurement error, you will see shrinkage. There's no shrinkage. Well, in an analysis of all of the patients on sugar pill-containing arms across many, many studies, we know that measurement error is 2%. You should expect a 2% response rate from measurement error. You're 100% right, but you don't expect a 10%. So it's 4 times the measurement error. So what do you think? Think about the design. Yes? Correct. So go on. Let's say, what if I were to say that getting pancreas cancer to shrink is like getting a train to move down the tracks? Just because you let go doesn't mean it stops. You see what I'm saying? He sees it. He's saying it's still the treatment that they got in the past that's exerting an effect, shrinking the tumor in the future, right? And shown here in the figure, what you get is chemo versus chemo. Then you measure it, olaparib versus sugar pill, and the shrinkage is happening from here to here. Here, 10%, here, 20%. And what I say is, if this is 10% from chemo that you're not allowed to take anymore, what would it be if you were just allowed to take that chemotherapy? It wouldn't be 10%. I don't think it'd be 20%. I think it would be 30 or 40%. So I think olaparib wouldn't be a drug that doesn't improve survival. I think olaparib would be a drug that's worse than the standard of care chemotherapy. So POLO, you halt a therapy that's normally not halted and you randomize people to a new costly toxic pill or placebo. You measure an endpoint that's not a measure of what matters. It's a composite time to event endpoint, and you historically has never been accepted in pancreas cancer, accepted because you can directly measure survival. You don't have to, it doesn't even save you any time. You don't improve survival. By the way, quality of life was not better in this study. So what does this FDA do in their infinite wisdom? On the question of whether olaparib had a favorable risk-benefit profile, the ODAC says, yes, narrowly in favor, 7-5. And they say the answer is, heck yeah, because pancreas cancer's risk is ultimate. So when I see this study, I don't think heck yeah, I don't think the giants are crumbling, and I don't scream in joy, I scream in terror, because they took people with an incredibly treatable pancreatic cancer, they deprived them of future therapy, which in my opinion is unethical, they put them on the novel drug, and had they just continued the standard of care giving more chemo, they would have gotten, in my estimation, 3 times as much chemo, and they would have probably done way better than if they'd gotten this drug. So to me, this represents everything that's pervasive in oncology and everything that's wrong. We can talk about where the errors happen, but it's not an isolated case. I mean, in our research, we show that, about 3/4 of studies, I could do something like this, give you a similar talk for. So what happened was we wrote this paper, olaparib, should it change clinical practice? We said no. And the Netherlands, they used to cover this drug. But then I went there and gave them a talk about it, and then they withdrew the drug from coverage. So they don't pay for this in the Netherlands. But in this country, we pay for everything, so we're never going to stop. All right. I have lots more slides, but I don't think that's as interesting as fielding your questions. So what do you want to talk about? I guess I will pause this on something. Oh, I don't know if you know this, but I put all my critical appraisal of all the oncology trials. If you're ever like, oh, I got to do a journal club on this trial, go look at how to read and appraise medical research, our YouTube video series. I got videos on like most things. And then we host this like website called Sensible Medicine, which we like review books and stuff. And we have this called Drug Development Letter, which is just oncology. I have my own Substack, but that's an acquired taste. Plenary sessions on podcasts I do on like mostly oncology trials. And then I have this book that if you listen to the audiobook, it's interesting a little bit. Okay, so I will pause, but I'm happy to answer any question about oncology, careers in oncology, being a medical student, which I obviously barely remember. No, I know so well, yeah, it's a long time ago. Getting into residency, gaming your application to get in good. No, okay, go ahead.
The hot topic nowadays, we're in a bubble about AI.
Oh, AI, my favorite. So I think I put up a lecture on the role of AI in medicine. Oh, I have the audio recording, and I put it out on my podcast. But here's what I think AI is. Gosh, where to start? Obviously, I think that like AI will have a role in anybody who uses the Epic chart. Like right now, when I see a patient I've never met before, I open up the chart, and for the next 20 to 25 minutes, I'm trying to find some information in a sea of complete garbage. They're nursing notes, they're contradictory statements. One says he lives in Portugal, one says he lives here. He has 2 kids, he has 4 kids, he drinks, he doesn't drink. He had this disease happen to him 4 years ago, he's cured, he still has disease. It's a complete mess. People are copying and pasting, nobody puts any effort into their notes. I do not know what's going on from looking at most charts. So what do? I spend 20 to 30 minutes and I go to like the original information. And the original information that I try to get out of it is, one, I get all the path reports, I get all the imaging, and I get all the administration of chemotherapy sheets. And I tell you this just to say that what I think AI can do is that anytime you open a chart, you can make an AI that will gather all that information for you. And the first page will be like a Wikipedia page. And it will be like Mr. Josephson, Wikipedia. And it's a summary of whatever, all the stuff that happened to him. And then every time something happens in the future, it's like every day it'll be rewritten because AI can just work all the time. That's one opportunity. Second, there have been randomized studies where patients write questions to doctors like, doctor, my ear hurts, what do you think it could be? And they randomize to AI responding or the doctor responding, and AI kicks the crap out of the doctor. AI is more empathetic, AI is better, AI can keep answering you. AI is probably going to take over a lot of these questions that like my inbox is like, it's like I'm drowning, I can't even handle it. So AI will do that work. Now AI will do some technical work. Right now there's a number of people using AI to like, you take a mammogram and you have a human look at it and they say, oh, there's 2 things that look bad. One thing is benign and the other thing is cancer. You make AI do that, AI finds more cancer than a human being, for sure, and less benign lesions. But is that a good thing? You should listen to I have like a long research thing on like why that might not be so good. But I do think people are trying to use AI for image detection, polyp detection. Now somebody's like, oh, well, AI can like read the biomedical literature and then it's going to tell you how to cure cancer. See, I don't think AI can do that because I just don't think that answer is in the biomedical literature. Like, you have like AI can only learn from what we have created, and we've created like a mountain of junk biomedical literature that's like not reproducible. So that's what I think about AI. Garbage in, garbage out. So like most cancer, there's a really nice study where they took like 70 papers published in Nature, Cell, JBO, and they tried to replicate those papers, and only about 40% could replicate the central finding. So if you train AI to read Nature and tell me what the cure for cancer is, 60% of what it's reading is not true, right? So you have to train AI to go to the lab and run the experiment, that's what I'm saying. Your other question was, before we started, was like, how did the IRB allow the POLO trial? Because you're like, the control arm is bad, it's unethical, all this stuff. How do they even allow it? And here's how they allowed it. One, there's nobody on the committee who knows anything about pancreas cancer. IRB, each university has an IRB and they pull in like one ID doctor and one person here. That's one. They don't know anything about pancreas cancer. 2, they don't want to be on the committee. I mean, like I get all these emails, say, come on this committee, come on that committee. I'm like, oh my God, I don't want to like donate my time to committee. It doesn't help me get promoted. It doesn't do anything for me other than take up my time. So they're not even paying attention in the committee. That's, I think, the reality. 3, it's a race to the lowest common denominator. By that I mean that POLO trial ran at 138 centers. All they do is they come to UCSF and say, listen, I'm AstraZeneca. It's nice to meet you. We have a new study. It's called POLO. It's going to be Where the Giants Crumble. Have you heard about that? It's going to be great. It's going to be the biggest thing ever. We've already opened it at 120 centers, including Sloan Kettering, MD Anderson. Do you want to open it at your center? And they're like, well, we got to send it to our IRB. I'm like, you better send it quick, because if you don't get an IRB approval, then you're just going to miss out on the party. And so then UCSF's like, okay, IRB, expedite, like, okay, approve. It's already approved at all these other centers. And all the other centers, they're like saying, all they need is one for-profit IRB to approve it, and then they can leverage that at every center. You know what I mean? You can just say, oh, it's already approved at Anderson. Oh, it's already approved there. And people feel like FOMO, that kind of thing. So I think for these reasons, that's why IRBs, they make 2 errors. 1, they don't stop research that's bad. And 2, they do stop research that's harmless. Like all of you all, when you do your retrospective chart review, your PI is going to tell you you got to spend 12 weeks waiting for the IRB. It's all pointless. There's no privacy that's being infringed on letting Chris back at some charts of a rheumatoid arthritis patient from 3 years ago. Like, he doesn't know, like, this is overprotective, I think. So I think they make 2 types of errors. Type 1, type 2 error. Okay, you had a question. You in the college shirt.
Yes.
I don't know your name. Nice to meet you. What's your name?
I'm Griffith.
Okay, nice to meet you. Good. Well done.
We kind of talked about here this baseline level of the IRB can prevent this from happening, and it seems like the final seal of approval is the FDA. So I was wondering what goes wrong in these FDA committees.
Oh, good. Well, hopefully it gets fixed because my friend Marty McCary is going to be the new commissioner. So that's good news for me. No, it's good news for Marty. It's good news for all of us. Here's what I think goes wrong at FDA. Number one, FDA suffers from revolving door politics. By that I mean the prior commissioners of FDA, Scott Gottlieb. Where does he work now? Board of Directors, Pfizer. Stephen Hahn, where does he work? Oh, he's on a venture capital firm that has significant investments in Moderna. Bob Califf, the current FDA commissioner, he used to work at Verily, the biotech company, and then he's probably going to go back to pharma when he finishes. So they keep revolving. So, there's the old saying, you go to Washington to do good, you set out to do good, but you stay to do well. And that's what I think happens to too often. They stay to do well for themselves. Two, among reviewers at the FDA, medical reviewers, like people in the trenches doing the hard work, we have a study in the BMJ. We documented what happens to them when they leave the FDA. 60 to 70% go to work for pharma. So if I'm going to go to work for pharma with 70% chance, I'm not going to say anything bad about pharma in my time at FDA. I think that's another structural part. The third structural part is that the expert class, like when it comes to pancreas cancer, even the FDA reviewers may not know. They're not running pancreas cancer clinics. They're trusting the expert class of doctors. That expert class has been, in my opinion, entirely captured by the industry. We have studies that show between 60 to 80% pharmaceutical coverage payments to these doctors, and they really have the ear of the industry. And then the last point I'd say is, there's the old saying, why does the rabbit run faster than the fox? The rabbit runs for his life, the fox runs for a meal. What does that mean? When it comes to regulation in any sector, from SEC to FDA, the people who stand to make tremendous profit from that regulation, they have huge incentive to lobby, because they're running for their life. The industry is lobbying FDA, they're setting up meetings all the time, they're talking to FDA all the time. But who is the person who benefits from strict FDA? All of society. But we have so little skin in the game, we're not spending our time lobbying. Most people don't know anything about FDA approvals. Most people don't know how they're approving drugs. They just assume that they're safe and effective if they're approved. And it's very difficult to get a huge disinterested public motivated to say, well, we don't just want cancer drug options, we want options that we know are better. This is a good example to me. I hear people say, well, even if they're not great drugs, more options is better than less options. But I'm showing you an example where I actually think more options is worse. Because if you never had this option, you would do chemo and you probably would have done better. So that's my opinion as to why. But that's just my opinion. A lot of people disagree with me. Yes?
So I think going back to the, use of placebo in the trial.
Yes.
Why was that allowed, or why is that common practice? I guess is it so you can do cross compatibility and kind of compare results for XYZ versus placebo and ABC plus placebo, or can they have a standardized method of care they can use to compare between these drugs?
Yeah. So good. So. All clinical trial ethics is you can randomize people to pretty much whatever you want is your experimental arm, but the control arm has to be the best available therapy. That's the rule. Now, why in all of oncology, most controlled trials do not use placebo sugar pill controls. Best available therapy is like old-fashioned chemo, it's like last year's drug, it's something older. You can justify placebo only in the settings where there is no best available therapy. And so the authors of this study went to FDA, and here's how I would sell it if I worked for them, but I don't. But here's how I would. So listen up, Susan. So that's okay. So I would sell it this way. I'd say, listen, dear, I'd say FDA, as you know, pancreas cancer is really bad, and we've had no new drugs in so many years. But not all pancreas cancer is equal. We learned increasingly it's a genetic disease. And there's some people that have the germline mutation. They're very different. They're younger and healthier. And all too often in our clinic, we don't have a chemotherapy-free option. These patients come to me and they say, doctor, I don't like chemo. I don't want chemo. We at AstraZeneca want a chemotherapy-free option. And the FDA says, but aren't the side effects of your drug just like chemotherapy? I say, oh, never mind that. The side effects of your drug are just like chemotherapy. Sure, but they want a chemo-free option. So what if we brought them in, we gave them some treatment, which is standard of care. A lot of people don't take a lot of treatment for all sorts of reasons. They don't tire of it, the cancer gets worse, all sorts of reasons. In our study, we're just gonna take them, and if they want to stop chemo, because these are people who want to stop, they want a chemo-free option, we'll let them take our pill or sugar pill. What do you think? That's how they're selling it. Not the way I framed it. But I think that's wrong. The FDA should say, that doesn't make any sense at all. If these people are tolerating it just fine, their tumor's not getting worse. In fact, it may be shrinking. And we all know that getting a pancreas cancer to shrink is like getting a train to go down the tracks. Wouldn't it make sense that you just keep giving chemo? Or what if the option was you're allowed to take chemo, you don't have to take chemo, something like that. So that's how I think they bulldoze FDA.
So more or less just boxing in the constraints of a chemo-free treatment option,
That's how, if I worked for the company, that's how I would sell it at the meeting, but I don't buy it myself, but yeah, you see. But there are other settings. For instance, there's a trial called fruquintinib. And a couple years ago, I was in Hawaii giving a talk. And the speaker after me was the person who wrote the study. And the speaker was like, oh, when the trial came out, everyone was so enthusiastic. Fruquintinib versus placebo in colon cancer. But there was one person on Twitter, one bad person on Twitter kept saying this was unethical, unethical, and this person is a terrible person, horrible person, the speaker's saying. And I was like, who is that person? I was like, who is this person? And then I Googled fruquintinib, and the single most downloaded tweet was my own tweet. And I said that, I was like, oh my God, it's me. I was like, I didn't know that. Oh, sorry. I was like, that's just talking about me, I've forgotten. But, so there are so many examples of placebo control inappropriate, I think. I think that's a problem. Famously, do you guys know about the HIV studies? Famously, when HIV medications were developed, like AZT, they proved that AZT was better than doing nothing for pregnant women about to have a baby. Then they went to Africa, where the cost of AZT is very expensive. And famously, the then NIH director, Harold Varmus, who actually used to work here many years ago, won the Nobel Prize, I think he and the NIH at the time, they permitted a trial that allowed half-dose AZT. So they let pregnant women in Africa who had known HIV, placebo versus half-dose AZT. Now, it was a big ethical controversy because people said, how can you we know full-dose AZT lowers the risk of HIV in the baby. And back then, HIV is like a death sentence, How can you allow yourself to run a trial where you go placebo for half the kids? And then their counter-argument was, we know they can't afford full-dose AZT. That's already the case. The reality is no one's getting full dose. We're trying to ask, is half-dose better than nothing? That's an important question. But that debate has, you can read the New England Journal, pro-con. So people have always debated the use of placebo in these trials. Any other questions? Okay, then I'll give one piece of advice. My only advice is, as you go through all your training, everything always feels, and it felt to me, really important. Like if you don't do a good step 2, you're going to be screwed, or you don't do this great, it's good. But as you get, the more perspective you have is that I always worried too much about the things that in the end of the day were just a wash, and it really didn't matter as much as I thought they did. And the mistake I always regret is signing up to do research projects that I did not actually want to do. I think you should just do things you want to do, and if that leads you to oncology, so be it. But to do these terrible, I don't know, whatever you think is terrible. For me, some of these projects, if you're not feeling it, it's not going well. There's no shame in telling the PI, oh, a lot of things going on in my life right now, and I decide I want, there's no shame in dropping these things, because the only thing I regret is wasting so much time when I was a student on projects I had no interest in. Okay, well, thanks for having me, and if you guys ever want some help in your little group, let me know. Okay.